think that raises the one challenge that the payer side needs to, faces on these is that, as you said, whether it's in one syringe or two, so the therapeutic options are available. I mean, they're available as separate agents. The opportunity to combine them into one syringe, of course, it's better for a patient. It's easier. It's only one injection versus two. And that's most likely, don't definitely have data on that specific issue, but in other situations where it leads to improved adherence, which of course is very important. But at what cost does that convenience come? Because it's not medically going to be any better. So it is, in a way, a convenience issue, but a very important convenience issue if they're not adherent.
And this is where you guys have to work with, pharma and managed care and physicians and patients all have to be on the same page and say, okay, if it exists as one shot, and it's so much easier for the human being with diabetes to accept one injection than two, let's all strive to make that one injection be available, because it'll pay off.
Agree with that, Bob, or do you sort of try to profile patients to think about who's the best candidate for the combination? And
yeah, I mean, certainly profiling and choosing the right person is important. I'm a little, I think convenience is sometimes used as a reason to say, well, that's therefore not important. I think framing it in terms of adherence, as you did, I think is really the issue. And so ensuring any medicine only works if people are adherent to it, and if they're more likely to be adherent to a once-a-day dosing than a 3 times a day, or whatever the comparator drug is. That said, what's the right kind of patient for this? There are a lot of patients that are started on basal insulin, and I think particularly in primary care, they've gotten very comfortable with using basal insulin and titrating the dose up. What often has happened is there's a large group of patients that are not well controlled that are on basal insulin, and many of them are not controlled, not because they need more basal insulin, but they're not able to make mealtime insulin, and that's where the GLP-1 agonist comes in and essentially becomes a choice between adding a GLP-1 agonist, which is going to have less effect on weight, less hypoglycemia, and could be the same number of injections that the patient's already on, or going into a basal bolus, which would be 3 additional injections and more weight gain. And if you frame that to most patients, they're going to choose door number 1 over door number 2.
I mean, do we also need to factor in the clinician time in terms of the various treatments, or the education time?
And this is another part of the fallacy of the treat to target trial based on fasting blood sugar, because at a certain point, if you just hit the person over the head with more and more and more basal insulin to drive down the FBG, you're not accomplishing much. And really,
except hypoglycemia.
except nocturnal hypoglycemia, right.